Good afternoon. This is the House Appropriations Committee. It is Wednesday, March 11th, 2025. It is 1:15, and we are continuing to hear from committee chairs about their committee letters around the FY26 budget. And we are delighted to welcome Chair Alyssa Black, Chair of the House Committee on Healthcare. So thank you for joining us.
Thank you.
We all should have copies of your material with us. So
Representative Alyssa Black, Chair of House Healthcare. First of all, I apologize for the scheduling snafu this morning. I forgot that our committee had a bill on the floor. And my trustee vice chair, unfortunately, is not able to be with us right now because he's running the committee. So we'll see what they get up to.
JFO.
I got my trustee JFO.
He really is trusting.
So I think I wanted to just broadly start with what our process was and how we came up with what we came up with. First of all, we took testimony on every single item on this budget. These are not just requests that were mailed to us or emailed to us. We took testimony on every single one of them. We then went through a very laborious process of culminating them, going through each and every single item. And I took straw polls on every item until it got so long because they were all 1100. There is not one item on this entire 3 pages that I have that unanimously every person in our committee felt needed to be on here. There were no questions or concerns raised over something that they did not feel was a priority and needed to be prioritized on here. 1100, every item. At that point, we then all take breaks, go examine our own feelings, very collaborative process, an equalized process. Everybody ranks their top 5 one-time funding and base funding. And then we go around the room and everybody ranks 1 through 5. Our JFO takes our rankings and our votes and tallies them all up. And what you have before you is 1 through 5 of what our committee collaboratively agreed were the top 5 base and top 5 one-time funds. I think we have heard testimony over 2 months. And the overarching theme is crisis. Our system of healthcare, our system of mental health care is in a crisis. And I think that these budget priorities, and they are all important, but I think what came out resoundingly is that we support the most fragile pieces and system in our system of care currently. We are prioritizing primary care. We are prioritizing home health care. We're prioritizing the least expensive, biggest bang for your buck services. And that's what I feel as though these budget items reflect our top 5. So first of all, we start off with the governor's recommends. We concurred with the governor on, I'm sorry, I have to take my glasses off to be able to see this. Everything that was in the governor's budget, we concurred with except for 2 cuts from the Department of Mental Health.
So these were cuts that were proposed by the governor.
Well, some of them are one-time and some base funding. So I wanted to talk first of all about the ACO transition bridge funding. It's $10.8 million gross, 4.4448. This is in the governor's recommend. This continues the per member per month payments that providers receive from the blueprint currently from Medicare. And this is bridge funding to get from the wind down of the ACO, which ends at the end of 2025, to the ahead model, which does not begin until January of 2027. if we move ahead with ahead. However, when we were looking at this bridge funding, it almost feels like the bridge is only halfway completed. And there is in the one time, our number one priority that was not in the governor's recommend is more bridge funding, which replaces the primary care providers that are participating in One Care. And they receive payments for a population health model. And also they receive funding for comprehensive payment reform. These are sort of capitated payments that they receive. If this funding is not approved, that would go away, and it would decimate primary care, and particularly independent primary care not associated with hospitals.
Rep. Harrison has a question, and then
You mentioned the head model. The head model doesn't go forward because Washington's changed. What does that do to your recommendations?
Well, by the time the budget passes, we won't know whether the head model is moving ahead, but
we still need.
we are working, we still need the money because the ACO is gone. So it would be one-time money, and then next year, we would have to come to, the knowledge that there's not going to be anything ahead. And, we'd have to make provisions for that. So, but this is working under the assumption that we are moving ahead with ahead, and it does not cut over $20 million, which is going to primary care currently through the ACO. That's funded by Medicare. That's Medicare's.
This isn't my area.
I think it's in the represents good.
I'm trying to follow you. You're using this, right?
I am.
Yeah. Okay, because at the top, you have of course, I'm really interested in this because I have the AHS central office.
Okay.
And I have Department of Health and
Yes.
things like that. So I'm interested in trying to follow this. So you're talking about the ACO transition bridge funding. The gross is 10.8 million and the general fund gets 4.48 million plus. And so those are what the governor recommends.
That's in the governor's recommend.
So you're talking about the ACO transition bridge funding to Blueprint. CHT, what is CHT?
So, community health teams.
Oh, and then SASH.
And do you know what's that?
I know what that.
Okay.
And the issue is the bridge funding connected to, was Blueprint under an ACO?
Yes. So Blueprint is administered through the ACO,
Okay, through One Care.
through One Care.
And then it would next it would go to the new program of AHEAD.
Yes.
If that should happen.
Yes.
Okay, because before there was One Care, was that something that was done as a capitation previously? Or?
It was usually done, I believe, under the Blueprint. Blueprint might have just.
It was its own thing.
It was its own thing.
Yeah.
And then the Blueprint got put, the administration
Of it.
and the allotting of the money was put into One Care.
Okay,
For One Care, for the record, no language, just office. Prior to One Care, it was just done for DDOT.
we just heard from them. Feels like a century ago, just 2 weeks ago. And it's like whatever what's in my brain is reconnect here. The Blueprint, is that patient-centered or is that institution-centered?
Patient-centered,
So they would pay
patient-centered medical home.
and they would pay it to the provider that was their medical home.
Yes.
Okay.
Yep. It's something like $2 and change
Yeah.
per member that's attributed lives to practices.
And primary care.
Primary care, yes.
Okay.
Um,
Then you started talking about this is only half of it. Where's the
Well,
other half?
So through the ACO, it's not just the Blueprint payments, it's not just the CHT payments or SASH. It's also the population health model program, and then it is also the comprehensive payment reform model. Those are also paid through the ACO, and those were not funded in the governor's budget.
Okay, that's the one here under household
Yeah.
care recommended of funding.
Yeah.
Blah, blah, blah. Okay, priority one, VDH, David VDH. So that's the piece here.
Yes, yeah.
So
So,
figure out where you went to.
so both those items are, if you add those together, that is really the total that we are losing from the end of the ACO until we get to a head.
Rep Krasinski and then Rep Blumen.
Yeah, just so I have more of a statement to make here, because I know there's gonna be a huge gap. Last day of this calendar, so. And here's for that fund to kind of fill that gap, you just can't.
Can't.
Hear that.
Yeah. And that's why it
So thanks
was,
for that.
and that is why it was, first of all, I appreciate that the administration put it in, most of it or part of it into their recommend because they realized how vital it is. And it is also why it was our number one priority. This supports primary care.
And this will probably come a little bit later on here and get to the line about Green Mountain Care Board.
Yes,
In the future.
that was my next thing I was gonna move to.
Okay, so that's that, we had Green Mountain Care Board, provide testimony here, we didn't quite get through all their presentation here, so we have lots of. Did they give some idea as to what the head model look like? I know they are looking for, and some staffing to kind of move toward that direction to see if it actually is going to work with what we have here.
Yes, so if we moved ahead with a head, the Green Mountain Care Board would be tasked with all the administration of it. Over many years, it would require, I think they're thinking about 25 positions. It's a huge payment model. And that's what they're thinking it would require. So if I could move to,
Please do.
yeah, so in governor's budget recommend as well was the 750,000 with 300,000 general fund. This was for 3 positions for the Green Mountain Care Board to start working on ahead and getting everything ready for, all the pre-work that needs to be done. However, when they signed ahead, the Green Mountain Care Board voted, and their stipulation was that they must have 5 positions. If they do not have 5 positions, they're withdrawing as signatories, and we do not move ahead with a head because they are obligated now to withdraw. So the governor put in 3 positions, and we have in our, in the other request for base funding made by the committee, it's on page 2, the last one, Green Mountain Care Board. These are the 2 other positions. If they are not funded for these 2 positions, there will be no ahead.
What happens if we fund the positions, if there's no ahead?
Then the money will go back into VAA next year. A reversion.
If they haven't hired people?
I don't think it starts, their cohort doesn't start until January of 2027. So we could figure out a way to get them in a position without funding it, maybe. Like Mitch, we'll figure something. I know what you're saying. We understand what you mean.
Okay.
I've seen the contingency list. This is not the only contingency that they have, but it's the only one that affects the budget.
Yeah.
So. Okay, Rep. Blumen.
At some point, you can tell me why 5 positions, like why that's a requirement. Is that a federal requirement? Each state must have 5.
The work to stand up the head model, to get it going, to do all the preliminary work. They made a requirement that they needed to be funded for 5 positions. And I'm sorry, no,
So I may well, as well. They testified that because there's 3 signatories on the head models, the AHS, Green Mountain Care Board, and the governor. Green Care Board made it very clear their signature to be part of the head model was contingent on getting 5 positions. They don't get the 5 positions, they withdraw, and therefore they don't have enough signatories from the Vermont side for them to move ahead on the head.
Gotcha. That's not my question. I'm sorry. It was just, but it was a question, clearly, because it came out of my mouth. But what I was going to ask you is on the one-time funding, you know, the primary care match. I mean, it's just it's an equal match, and I'm just wondering why the match for the bridge funding for the first item is, you know, 4.4 million to 10 million global commit.
Well, it's not global commitment, so there's gross and there's general fund.
So, but
in
the
this
rest
case,
of it
there's
is,
no global commitment on the second part.
okay.
So the
Thank
question
you.
might be,
No match on
why
it.
isn't there global commitment?
Why isn't there global commitment?
Could,
I believe that it had to do with helping those providers make that transition. I can't remember if we put that as not global commitment because we weren't sure, or if we were sure and that's what we came back with. But right now, we're operating under the assumption that that particular line item would not be. It's not global commitment.
I'm going to ask a question, then I'm going to pass it to Lynn. So am I understanding that the governor's recommendation, here we are, we're still on the first topic here, but that's okay. The E1100, the global commitment transition, 10 million aid, 10.8 and 4.4 only covers half a year?
no, it covers a full year of those payments that the ACO was making. And those are payments that Medicare was previously, well, not previously, but they are currently making. That's Medicare's,
Okay.
it's making up what Medicare isn't.
But it's not, it doesn't cover the primary care and the FQHCs.
Not those models under the ACO.
Okay, and it's only half a year, right, because that's all we got.
Yeah.
Lynn,
Okay, I have the Green Mountain Care Board budget and talking to people from the Green Mountain Care Board. It sounded to me like One Care was an institution and we put money into that and they did this payments and this thing. It was a private for-profit.
I think they were nonprofit. I think they started as a
And then they
for-profit and they might switched over.
So the problem is that now whatever they were doing, making payments and doing the administration. And I could be wrong about this, but HED was going to be doing that job now. And it was going to be recreating essentially One Care under the Green Mountain Care Board without that overlaying bureaucracy of One Care. But it was going to build up the administrative staff of the Green Mountain Care Board because they have 4 people and it's a very small group.
I will be very, well, yeah, I'm gonna let,
If I
Nolan.
might, the board's coming in at 3 to do their budget. Maybe you could put a pin in that question, ask them.
Yeah, but that was my understanding is they have a very small budget because everything they do is bill back from the providers, the hospitals and all the people they regulate. So they really have a small budget. And the bill back pays most of it, but this is gonna be like, we're gonna create another medical bureaucracy now with Green Mountain Care Board to do what One Care used to do.
It would be different.
If that's true,
I believe it would be difficult, but again, I would,
somebody's gotta do it and they're putting it there.
what the Green Mountain Care Board would be doing is different than what the ACO would do. But again, I would defer to them to explain it to you better, but it would be different. And the role the board would be doing is different than what the ACO is doing now.
so is that going to be in your committee, Alyssa? Is there coming in 3, you said?
No, they're coming here. Oh, no, I'm sorry, they're going out Senate appropriations.
I was like, years ago. I had other people on my agenda.
I'm sorry.
My question is,
My apologies.
How is
this
it?
is my question, is it the same? Are they gonna be doing the same job? Are we just shifting one payment to another place?
Different,
No.
different program.
it's a whole different program, different payment model.
I understand the question.
Yeah.
Do in the budget, you know, basically you're asking the structure of what the ACO is doing, that what the board is going to be doing, and the answer is no. The board, what they're needing, and what their need position to is to be able to implement whole budgets, to be able to regulate the system. They're not gonna be the ones making the payments, they're gonna be the ones sort of overseeing. Payments will still be going through the regular, I believe, through the regular, just our processes within DEVA.
So that's a data issue more than it is.
Yeah, I understand, it's a great question, I understand what you're trying to ask.
Yeah. Okay, thank you.
Okay, oh, wait, we got another.
Oh, I'm sorry.
I'll let you go ahead.
So, when will they have, when will there be a decision to whether you're gonna go ahead with the head model or not?
Well, they have signed it
So,
and it is set to begin in January of 2027.
January 2027, so the positions will not be doing any work until 2027.
No, they'll be preparing and getting it ready. I mean, it will be, essentially, it will go live in 2027, but there's an enormous amount of work that needs to be done prior to going live and working with CMS in how it's all implemented,
So that would start in 2026.
start in 2026.
So I just have one clarifying question, because it sounds like they came to you and they're looking for 5 positions. When they presented us, they're looking for 4 positions, 2 permanent and 2 limited service.
No, they have 2 limited service positions also with not affiliated with the AHEAD. It's actually the very last item on our spreadsheet in the one-time requests that we received. We did not rank it highly. I mean, it's important.
It's just a question.
I think that they wanted to,
Maybe I should sit up there.
I know. I knew this was gonna happen. I'll be honest with you. I looked at the budget today knowing I had to come in here and I'm like, I don't remember any of this. It feels like it was
So last month.
Excellent.
okay.
I just, you know, I just was hesitant to sit up here because it's the committee's recommendations. As the staff, but.
You were not just
But
any.
you were supporting the budget
So
and you.
again, for the record, Nolan and I will join this law, is what the Green Mountain Care Board asks for in their budget is what they need to just do the work that they're doing.
Right, I understand.
And so, and I think they had asked for more positions than that when they were doing their budget instructions through finance and management. And finance and management just gave them only allowed them to do, I think, 3 positions in the budget. They're asking if you're going to do a head, we need 5 specific to a head. So it's 5 on top of the 3, because the 3 that's in the budget is just for them to do the work that they're doing because they're feeling understaffed.
Yeah.
So this is, I think that's a big piece of it. And there's some overlap too. So, you know, if Owen were sitting here, if I was channeling Owen, he would say, well, the head people aren't going to just be doing the head model. They're going to be doing a lot of other stuff too. So they're just overall understaffed to do the work that the legislature and has prescribed for them to do. So they're just trying to staff up to that capacity.
And I understand all that stuff there, but I'm also, I know we have to kind of focus on like the current budget here for the next fiscal year, but looking ahead with them looking to have to build up to, you know, 15 permanent and 4 more limited services, what they gave us in the proposal here, how would we do that? I mean, that's not a question to answer today here, but I'm just kind of putting that out there because they gave a presentation, they had 2 + 2 is what they gave us.
Okay.
That was what that is here, and that's what I understood. And I'm aware that they were looking for like 5 total.
Yep.
versus-
They were given 3. Then they wanted 2, and then plus 2 more just to do the work that they're currently doing on other things, because they're understaffed.
That didn't include the other.
So that's 7.
Yeah.
So 5 for a head, 3 in the governor's recommend for a head, 2 additional for a head, to be able to move ahead with a head, and then 2 limited service positions to just do the work that they're struggling to get done.
I guess that wasn't clear.
Well, I think what makes,
Not purposely so. They were trying to shit a lot of information.
I think what makes it confusing is that because there's overlap, it hasn't been clear. I think the question to ask them would be, there's 3 in the budget. if we gave them two, would that make the five for ed, or they want five, not including the three that are in the budget? That's the question I would ask.
Which is kind of what I understood from like finance management, to just go over the large scale budget.
So we'll get that clarified.
So I think it just needs to be clarified.
Yeah.
I'm not opposed
It's a
to it.
split budget, so we can just figure that out.
Yeah, I'd like to be able to figure out so I can.
So-
Right, exactly. We all would like to know
So
about it.
just-
Wayne?
To further this discussion, the three positions that are gonna stand up the program, they're gonna be developing and standing up the program first here, right? The question then is, are those the same people that would be required after the program is working? Or do they have the
Yeah, it's the same question,
Yeah.
exactly. And to what I was just saying, like, would the three count towards the five? Or is it five on top of the three?
And so technically, do they have the same skill set required to stand up the program as?
Well, it's not standing up the program, it's about being able to regulate the program. So it's about, again, I would prefer them to be here to answer this, but I think it's not about standing up the program, it's standing up their portion of regulating it.
But I mean, it's methodology, creating the methodology that would be employed once the
Sure.
thing was up and running.
Yeah.
So is the skill set for doing that part of it going to be the same as what would be required later on to run it?
Again, they're not gonna be running it, but the answer I think is yes. But there's a lot of confusion about this, as I can tell, so I will connect with them and have them maybe provide a little more information
Okay,
to clarify.
Yeah, thanks so much.
thank you.
Because it is confusing, and then they have.
Let's go on.
Like three.
This committee often gets to page 3 and stops.
Remember I said the committee process was laborious? I didn't realize I was gonna relive it here today. So the other things that I really wanted to mention were the two line items in the governor's recommend. He recommended cuts to first call and embedded clinicians in pediatric offices, and then a cut to the Howard Center for their community outreach program. We took a lot of testimony on this, actually, and frankly, there was a lot of confusion over what they were saying that they were cutting and what they actually were cutting. And particularly the community outreach program for anyone in Chittenden County, most of the towns participate with the Howard Center, which is our designated agency. And they have multiple types of outreach. They have community outreach, they have mobile crisis, they also have first call. And each of these types of outreach have different levels of who you can go out to, the services that you provide. And I think that the feeling that we were getting from the Department of Mental Health was that all this could be just rolled into the mobile crisis unit. But these aren't necessarily crisis units. These are people for the Howard Center that are out constantly in the community, working, doing outreach with people. They're also, I mean, our Representative Houghton from our committee tells about, there was a woman who was hanging out and every day and very erratic, seemed to be in sort of mental health crisis, who was outside the flower shop that they own. And, you know, not disturbing anyone, but just clearly someone in need. That is not a first call. That is not a mobile crisis unit. That is not a crisis. That is not a police officer coming and, you know, exacerbating the situation. That's what these community outreach programs is. And we recommended to keep them in the base. They are currently in the base funding. They're recommending cutting them because we would like some more clarification on how they plan on integrating all types of mental health outreach So we're recommending that we continue funding them for one more year until they can come up with a plan. And that is in our budget language, which it occurs to me, I forgot to bring the budget language that I have with
We
me.
have access.
We will need that.
Yes,
You can just-
I sent it to you.
Oh,
You all have it. I just have to bring it to have in front of me. So we do,
In front of you.
yeah, so we do have some language in the budget regarding that. Oh, thank you.
Thanks, Aaron. Okay, thank you.
So we're recommending that it continue for one more year.
All right, Jen has a question.
No, I don't. I just want to, our committee was also told that this Department of Mental Health saw this as perhaps duplicative, but in conversations with members of your committee and people in the community, they said they are absolutely, totally different from the mobile crisis.
Yes.
These are people who actually know all the folks who are sleeping in doorways, who are, wandering around downtown and have a relationship with them, which you don't have with mobile crisis. For a reason. I mean, mobile crisis can address it and move it on.
And mobile crisis can only go out if they are specifically called and requested.
Yeah.
Okay, so is there anything else in the governor's we are recommending everything else that's in his,
Okay.
okay.
Let's keep going now.
So, yeah, go
And I
ahead.
do have an answer to the board question, which we can come back to later.
Okay, hold it.
Okay. So continuing our priority of primary care, again, we have prioritized the pieces of our system that are in the most fragile state. We will lose, and we will start losing lots of them. I think we might have learned some of that when we were doing the BAA around some crisis stabilization grants. So our number one priority is to increase the FQHC Medicaid rates to be more in line with the rates that it actually costs to provide services. Keep in mind, I say move them more in line. They're nowhere close being in line, and even increasing them doesn't move them into alignment. We have been trying to increase the rates, I think, to 90% of what Medicare pays. And I know my entire time in the legislature, we certainly haven't gotten to 90. I think we're at 70 something. 60, it's 67. Oh, no, that's home health. That's home health.
Just quick clarification.
Yes,
Vermont Care Partners, do those fall into the category designated
Yes.
agency?
yes.
Designated, not,
DAs and SSAs, designated agencies and special service agencies. They are a number 3 recommend. They are the agencies in this state that, and I know they do a lot of other things, and Human Services will come in here to talk about, all the stuff that they do through Dale. But this is our system of mental health care in this state. And they are the ones that provide the services, and they are continually level funded, and they have an incredibly difficult time hiring staff because of their pay. And they're being asked to do more and more with, less. Number 2 priority, home health rates. Home health is vital to every other line in our continuum of care. We have people who are unable to be discharged from high-cost inpatient settings. We don't have enough beds in inpatient settings. And we can't discharge them to home because we can't find the home health that they need, the nursing care, the follow-up care. People cannot be discharged from skilled nursing facilities because of home health. They are I always use the word biggest bang for the buck. They are the cheapest, most efficient care that we provide, and we provide it in the setting of patient's home. I guarantee you, if you went around your table at some point in all of your lives, you've had to deal with home health. And if you have to deal with home health, you understand just how vital it is for you and your family members. So they are number two. The number four.
Right, because we talked about number three, so we'll skip to
Yeah.
four.
Do I get to take chair's privilege and say that number four is actually my number one?
You're welcome. Share that information with.
I put in it as my number one, but my vote is equal to everybody else on my committee. Bridges to Health, they have lost their grant funding through UVM extension. We are recommending that we move them from one-time funding into the base. We have right now, this year, they are currently funded through the end of September of 25. What year are we in? End of September. So they only need in this year's base 9 months of funding, which is the 675. And then in the future, it would be 900 in the base.
Can you remind folks what Bridges?
Bridges to Health is an organization that works with particularly our agricultural worker community who have language barriers and no access to healthcare. And they connect them with services and help them navigate our healthcare system. I mean, I think about with COVID, they were the ones that were going out and giving COVID shots to farm workers. And I just think the work that they do is amazing. They do it on a shoestring. I've seen how much they make. They don't make very much money. They deserve so much more. And they keep a population in this state that is so vital. Our agricultural industry would collapse without these people. And these people are unseen and unheard. And to me, it's the best money we spend. But okay, I'm sorry. I told you it's my number one.
We appreciate that.
Very, very fond of
Okay,
bridges.
vaguely remember hearing about this. It's in the Department of Health. So do they work for the Department of Health?
No, they're part of UVM Extension.
UVM Extension.
They are a nonprofit out of yes.
It's a
and-
nonprofit.
It's a nonprofit, previously grant funded organization. I think they've been around maybe 8, 9. Do you know how long, Bridges?
Okay, so this is out of the Extension Service. Now, are these volunteers who do this?
They're not volunteer. Well, there are volunteers. There's a lot of volunteers, but they do have a few paid positions.
My area, we've got a lot of these workers.
Yeah.
And we have people who volunteer to drive them or their families or whatever to doctor's appointments and all the usual stuff. Right. Not just healthcare, they go to the supermarket. Actually, sometimes the families go to the supermarket and buy huge. When we're doing it. It's huge bulk. But it seemed to me they were volunteers. Now, are they paid stipends? I mean, how does this work?
I believe that Bridges has some paid staff and then they work with volunteers that help them support this because they are throughout the state.
So the people I know who do the volunteering, they're part of this,
I think that they would be working under
this. Okay,
this.
thank you.
So what would they be using the money for? For the paid staff or
For
for?
the paid staff, yes. So number 5, and it was tied, we had a tie. Nolan insisted putting on the tie on there, but I thought we should flip a coin. So the Vermont Network has requested 1.2 million. And I have to be honest with you, from my recollection, I believe this is training and instruction for forensic nurses who are throughout the state.
Yeah, Trevor, do you remember what they?
I'd have to go through my notes.
Yeah. I was thinking it was something else, but that may be.
I thought it was too.
I think we all think it's something else.
Yeah,
It's not that.
I would need to get clarification.
That's all right. We
Yeah.
have it. We have the information somewhere. It's good to know that this is one of your priorities.
And then Planned Parenthood of Northern New England, they receive, there's a family planning rate that they get. And it has not been increased in quite some time. Planned Parenthood is in pretty dire financial straits right now. This doesn't even come close to what they would need, but it's a rate increase that they haven't had. Essentially, anytime they do a service that has anything to do with family planning, they get a specific rate from DEVA. And this is for a small rate increase for them.
It's quite a match, isn't it?
Yeah.
You give them 85, they get 850.
Yeah, it's a
Yeah.
federal family planning 90/10.
So that's a big bang.
Yeah. So, yes, great bang for the buck. And then we have, I won't go into other requests. I will say, I'm going to, just because, again, I'm going to take chair's privilege, is the Medicare Savings Program. I don't know if you all recollect, last year, we raised that to 145, the Quimby level. It might have been
That was, this was the Medicaid, when you're on
Yeah,
Medicaid,
when-
when you go to Medicare and there's a cliff.
Yes, and it was 100%. Okay, so you're on Medicaid up to 138% of the poverty level. And then you hit 65, become eligible for Medicare, and all of a sudden, at 100% of poverty level, that's where we had set Quimby. Quimby is a program that pays your Medicare premium. It pays for your coinsurance, deductible, cost share, all your cost sharing under Medicare. So it's kind of like, think of it as a supplemental
What's the stamp
that pays
qualified
qualified Medicare beneficiary. So
Medicaid or Medicare beneficiary?
Medicare.
Medicare beneficiary, okay,
So last year we raised it, so there was that cliff.
right.
We raised it to 145. The thing is though, that there's all these other sort of Medicare savings program categories where if you raise one, you get to then raise other ones. And there's a program, we raised it that much because that would allow us to raise our FPL level on what's called QI. And QI is actually 100% federal dollars that pays for all your deductible and cost share. And that's a federal program. And so to get more people qualified for that, we raised our Quimby up. However, it might have been a bit of an oversight. So there's also this LIS, low income subsidy, which is for prescription drugs for people on Medicare. And it's also a federal program. And that goes up to 150% of FPL. And so if we aligned our Quimby up to the 150% of LIS, we literally get every single month from CMS, Center for Medicare and Medicaid Services, we get a LIS list. And it's everybody that's qualified up to 150%. And we manually, DEVA manually goes through everybody on the list to see if they would qualify for Quimby. And if we aligned the Medicare Savings Program and just increased Quimby up to 145, then we could not have to do this reconciliation with the list. You would just automatically, if you're on if you qualify for LIST, you would qualify for Quimby. So this doesn't include any administrative savings, but there might be some in there. And also by raising it to 150, it would also allow us to raise our QI up another 5%, that's another 5% of people at, I think it's 200%. I think right now we set it to 190 FPL. So that's another 5. If we go up to like 195, and that's
More money.
that's more money for Vermonters.
Oh, for Vermonters.
For Vermonters, that's
So do we know, and this
that's
is, you know,
that's prescription drugs.
okay. Where other states land on this, Nolan, do you have any sense? Is 150 kind of where,
You know,
or is it all?
I am not the right person to talk to about the Medicare Savings Program, so.
Okay.
The right person to talk to, I think, would be our healthcare advocate. I'm pretty sure he
Yeah.
runs around with
All the-
tables in
Yeah.
his back.
Just, okay,
That's
that's fine. Well, we'll keep going because these are below number 5.
okay. So those are below number 5. So let's move to our one-time funding requests, priorities.
Top of the page.
Middle of the second page.
Healthcare recommended funding priorities one time.
Yes. So we already talked about the one-time bridge funding. This is that is our number one one time. Now SASH is included in the governor's recommend, but that's SASH. SASH has extended a program, I believe it's Brattleboro. I think it's Brattleboro. And they have a pilot there and they would like to continue that pilot. And I don't know if you've had SASH in here, but SASH does great work and it's wonderful community resource.
We heard a request for 2.4 million, so 400,000 was to maintain it in Brattleboro.
That's to
2 million
maintain it.
was to expand it.
Yes. And we put in the maintaining, and if you look down in our other funding requests or one time, there are several programs through SASH. We did not rank them as highly as just continuing that pilot.
Okay, Wayne, you have a question?
Yeah, what's the name for SACS? What's the acronym stand for?
Support and services at home. Don't ask me to tell you anymore.
So I need to.
Got that?
You were good to get that.
Every acronym that exists comes through this committee. We don't remember all
Is
of
this sort of like home health?
So they sort of work with our senior populations and disabled that live in sort of congregate housing developments.
So it's not, the other one works for just a single people at home or?
Yeah, home health. Home health is if you're in the hospital and you have a surgery and you need to have your dressings changed every day, that's your home health nurse that would come out and do that.
These are going into like nursing homes or?
Well, it's run by Cathedral Square. So if you think about something like Burlington, it's Decker Towers.
I think we have some more info from Tom.
So the original SASH was primarily before all of the SASH programs were in affordable housing or near affordable housing. The original one's for seniors living at home. And SASH for All is family oriented. They are service providers that will come and make home health visits. The old school thing about homeschool visits, home health visits. The thing to know a little bit about the organization is that when you see the $2 million later on, it's for 10 panels. They're called panels. So there's a panel is a group of individuals who are treated by a team of home health providers. So that the panels tend to be 100 people or whatever the number they determine. So it's not scattershot. The services are not required. But they have shown over the 10 or so years that they've been a little bit more than 10 years, starting with the senior program, to be as cost effective as anything else because people are being visited and checked on a regular basis. And so they've been very slowly expanding as funds become available to go as far statewide as they can. It's an incredible, it really is an incredible program. While Theater Square runs it, it's managed also by other nonprofit housing organizations across the state. So it's really it's a great foundation, and it's bringing healthcare to people who either may not or would not get in a vehicle or have transportation to get to see a doctor. So
Perhaps the least expensive,
what's that?
perhaps the least expensive way of giving care to these people.
I will never use least, but
Less.
it is less. It's proven,
Yeah.
much like I think we took testimony on pathways on the cost of keeping someone in an emergency room versus keeping someone in an apartment with services. It's like $100 a day versus thousands of dollars a day. So this is just a way. Yes, if you get to an emergency room, you're automatically more expensive than if you're being handled at home.
This is one time, but it sounds like it really should be base.
So just,
Well, this is a pilot.
The 400,000 I was looking at.
Yeah.
Sorry.
just like on that discussion there about the cost differences, I have a neighbor and his wife told me last weekend that he's in bad shape. That, they come in once a day, or whatever, it's $500 a day is what it's costing. And so I'm just wondering, where would that service be coming from?
I should interject, but Sash is more of an advocate for the person.
Okay,
And just by way of disclosure, I believe it used to be Medicaid funded or with some kind of federal funding before, and then it got out of it or something. I'm not sure.
We have 3-year pilots for
Okay. My wife was actually a Sash coordinator in Rutland for a time. And she got, permission. She would be calling the doctor's office for them.
okay.
These are people that don't have necessarily the abilities to do it themselves.
So they're not the actual care provider.
They're not the care provider.
Yeah, just to get it clarified. So home health, as you go to the hospital, you get an operation, you're probably going to be more independent unless you're going to be a candidate for a skilled nursing spot.
Mhm.
If you can go home, if you can get home health to come in and they can get you through those first few times, okay. If you're a candidate for more serious than that, a candidate for a nursing home, you have to find a spot in a nursing home, that's all. And usually the hospital keeps you there
So you can
longer,
find that.
okay.
Yep.
For Sash, so well, Sash is an advocate. I'm not sure that Realize was an advocacy. They have someone who helps you do this. And when we did our field trip last year, we went around to some of the lower affordable housing.
Oh, that was 2 years ago, right, yes.
Where we went to places that had an office that was probably a Sash office or something in the building, that people were there. If they needed anything, you could access it. They didn't do the work, but
Yeah. I don't think of SASH necessarily as delivering healthcare. SASH coordinates care, and they coordinate in low-income senior housing, sort of coordination of services that people need. I also think of them as being community builders. They, there's the social aspect, and for people who are oftentimes isolated. And so I think of them as more coordinators of programs to help people be able to continue to live independently.
Yeah, and to add to that, if my experience or what I've been involved with is that home health agencies, often you have to wait for their services, so people hire things like Bayada and other private.
Right.
And we have.
Ada is one of our.
Yeah, there's probably a few of them, but they bring people in and they take care of you. You got to pay for that yourself.
Their home health provides different types of services. Our home health agencies, and human services, I'm sure will come in on their piece. What we're talking about here is we're talking about the rates that they receive from Medicaid for medical care being delivered. We're talking strictly about VNAs as of nursing care, not sort of home help. You'll have somebody come in and help you bathe or dress. That is not this. This is, I had occasion of a family member had home health. He had sepsis and had to leave the hospital with a PICC line. And it was either be in the hospital with the PICC line for 30 days or go home, and a home health from UVM Home Health came to the house every 3 days, flushed his PICC line, kept it clean, made sure that, medications, all of that, and changed the dressings on it. It was either that or he would have been at the medical center taking up a bed on
Costing a lot.
Yard 6.
Okay, so I'm looking at the time.
Yes.
And we're almost out, and we still have a few more things we want to get to.
So, there's through the blueprint, the community health teams, this is, Nolan, can you help me with this? So there was a pilot, a blueprint pilot. I don't know if anyone remembers this from last year, where it was mental health integration, which is essentially Blueprint was piloting for substance use treatment. You're not just treating substance use, you're treating the whole person. And it was mental health integration in spokes or in hubs with substance abuse. And the other piece of it was the Dulce program. Dulce is it was a pilot through Blueprint. It's in pediatric practices, and it's like an embedded social worker for all new families, new babies. Every single new baby has a Dulce person who is working with the pediatrician, and oftentimes they're able to identify, any sort of help or support that a family may need that the pediatrician just isn't able to actually discern from the occasional well baby visits. And they work with families to make sure that new families with newborns have all the services and are connected with the supports that they need. So this is a request to continue that pilot that has been working really wonderfully. I have to say, I think we heard from more pediatricians on this than almost anything, just what a change it has made in having that person in their practices to work with them and helping out families.
So we have a question.
Just quick, so in the notes, it says unspent FY 25 appropriations may be carried forward in House passed BAA, and I'm just wondering what is that amount? And does that affect the number of the actual ask?
Do you think you can do that?
I don't know the answer to that.
All right, you'll get back to me.
We can get back to you.
Okay.
Let's continue.
Thank you. Maybe,
Oh, that was the PAA thing. Yeah, we'll get back.
Maple Mountain Consortium it's at Gifford, and this is a residency program for family medicine that they are looking to fund. And a new program. And it creates a primary care pipeline. Because right now we only have one hospital in the entire state that has a residency program, and that's it. UVM through Larner College of Medicine.
So we would be funding the residency as opposed to the federal government funding residencies.
Yes. Well,
Well, because there's a finite number of residencies, right, that federal government pays for.
it's opening up, I believe they're receiving federal funding for this as well. I'm really sorry. I can get back to.
We do this in, it's in the, I think it's in the global commitment, 301. They pay for residents. We have residents and we put something toward it and then
2025.
UVM
Right,
pays the state share, I think is how it works.
right, and then they get
So
federal.
we pulled out federal money.
Yeah,
We're on that one.
but there's a finite number of residencies. Congress decides the number, and if I'm recalling this correctly, they haven't changed that number since like 1971. Which is kind of crazy. Yeah,
This residency would be at UVM.
no, this one wouldn't be. This would be
Gifford.
This would be at Gifford and,
New and state paid.
Yeah.
brand new.
and training in a more rural setting.
Don't the residents at UVM go out into all kinds of other places? I mean, that's not unique. You don't have to go to Gifford to have rural, if you're already at UVM, I think they go out and work all over.
Well, they do, you usually do some, some clinical, 3 months here, 3 months there, whatever, but they're still associated with UVM. This would be a brand new program, because clearly they're trying to attract doctors in more rural settings, primary care.
And I think that would be more med students. You do rotations, you do clinical rotations as med student, but typically once you're in your residency program, you're within the facility that,
Yeah.
right, that staffs you. And so this would be opening up, a pipeline, for primary care. And then our last, priority number 5 for one time, we have a, emergency service provider commission. And they are not currently funded. They're housed within the Department of Health. And they have requested $160,000. And this would provide training and support. I don't know if any of you remember or recall, I recall this vividly. We set up the emergency responders, sort of commission to respond to the mental health needs of our emergency responder workforce, police, fire, EMS, 911, anchors, and just the trauma that these people see every single day and the cumulative effect of that on your mental health. And so we set up this wellness commission and to make recommendations and do trainings and peer support and all sorts of things around the mental health of the people that we call when we're in our worst hour or time of our lives. And so this is one-time funding for training.
So are these people employees of?
So, actually what this is, well, we had, I think it was the chief of Burlington Fire Department. And you think about Burlington Fire Department has a paid fire department, but this is for people who actually have the training and the skills to be able to go to other parts in the state where it's volunteers.
So you said it's Department of Health, so
No, the commission is just housed within the Department of Health.
they're not.
They're not paid at all. They are not paid at all.
Just wondering if we're doing something that Department of Health should already.
No, it's just a commission that meets and
The Department of Health has an EMS section that does a lot of the regulations. And so that's where their EMS expertise in AHS lives in Health Department.
Lynn?
Yeah, there are 3 of
Well, then I
these
gotta
listed
check.
in here, real quick.
Yeah.
You got this one for the 160,000,
Mhm.
and that is to fund secure. And then on the next page, you have one for, again, emergency service providers. One time 50,000, and then another one for.
yes, they had several requests.
So they've got 10,000. So are
Yep.
these all the same or?
Same organization, the commission.
Request.
They're just different requests. We categorize each individual request.
So your higher priority is. the
Our
one that's-
highest priority is to fund mental health training for emergency service providers across all sectors and across the whole state.
So we're not gonna go through these. These did not make the priority cut, and we already have 300 and something dollars. So we won't.
They all made the cut. They are all fully 100% supported by House Healthcare. They're all important. But
And
we had to do 1 through 5.
we did, and I really appreciate you all.
And the number.
Doing the best you could to cut back. We have, as you know, a tough budget year and a lot of, you cover some critical human needs in the state, so. I think it's important to think about it.
If I can answer
Oh.
the board question real quick.
Yeah,
All right, so I found some language that they had sent to me. Essentially, they are getting 3 positions in the budget. They have one ask on that one, which is, those are coming out of the pool,
yeah,
vacancy pool. They are asking that these actually be created positions because there's some uncertainty when you go to the pool.
yeah.
So they're asking for the positions, and there's 3 positions: a health systems financial principal analyst, a health systems access principal analyst, and a health systems quality project manager. And then if the head model, so they want those regardless, and then if the head model goes through, then they want 2 more positions: a director of global budgets and a procurement officer. And then they also are asking for 2 time-limited limited service positions as well on the side. But I think the 5 is basically the 3 that's in the budget already.
And then 2 more.
And 2 more contingent on if the head model moves forward, to be hired by September.
Okay, great. Thank you very much.
Thank you.
Thank you for coming in. We really appreciate it. Committee will take a break and go offline.